Thank you. It's good to see you all again. Again, at Atrium Health Carolinas Medical Center, we'll be talking with you about our experience with robotic pancreaticoduodenectomy. Again, here are my disclosures, same as before. So robotics in pancreatic surgery has shown lots of promise in the field of HPB surgery. Many studies have shown improvements in length of stay, ICU admissions, complications, pain scores when compared to open. Again, at our center, high volume HPB center that performs mainly MIS. As previously stated, we started our robotic HPB program in 2006. We have 4 robotic surgeons at our program, and 2 of them perform robotic pancreaticoduodenectomy. In 2020, we then introduced our robotic HPB fellowship, which is the first of its kind, a 1-year dedicated fellowship after completion of HPB or a liver transplant fellowship. First described over 20 years ago, robotic pancreaticoduodenectomy has since been accepted across the globe, performed at mainly high-volume centers. However, historically, patients have been highly selected with pathology such as benign diseases of the head of the pancreas, cysts, neuroendocrine tumors, chronic pancreatitis, and more importantly, resectable malignancies, ampullary carcinomas, small pancreas cancers, distal cholangiocarcinomas, those with favorable anatomy for reconstruction. And also patients at low risk for complications, and even more specifically, no prior abdominal surgeries. And so for open Whipple procedures, there's been benchmarks that have been described by the Clavian group in 2019 that are used as standards as comparison for open pancreaticoduodenectomy. However, currently there is no specific benchmark for robotic pancreaticoduodenectomy, and there's been no comparison of robot Whipple procedures to these open benchmarks as of yet. These are the benchmarks that are that were listed and described by Clavian in 2019. And so for our study, we aim to describe our experience over the last 10 years with the robotic Whipple procedure and compare our outcomes to those for open benchmarks. We also wanted to exclude those patients at high risk and low risk and describe those outcomes separately, and then also describe our institutional learning curve. So again, we did a retrospective review of all the robotic Whipple procedures performed at our center over a 10-year period. We categorized our patients into low and high risk groups, and those are based off of the low risk criteria that were set forth by Clavian in 2019. We then later grouped our patients into specific chronological groups that represented different inflection points across our learning curve. The low-risk patients, historically, the criteria based by Clavian in 2019 had low ASA scores of less than 3. They were not diabetics who used insulin. They did not have previous major abdominal surgery. And they, importantly, had resectable malignant or benign disease of the head of the pancreas. So for our results, we performed from 2011 to 2021 over 1,400 robotic HPB procedures. 418 of those were pancreatectomies, and 215 were Whipple procedures. We had 14 patients that were lost to follow-up, so we included 201 patients in our study. This is our table looking at demographics between the low-risk and the high-risk group of patients. As expected, there was a difference in age, ASA status, and then also there were more patients in the high-risk group that were diagnosed with pancreas cancer. And we also had more patients in the high-risk group that received neoadjuvant chemotherapy for those patients that had pancreas cancer. Here we have a comparison of our postoperative outcomes between the low-risk and the high-risk groups, and then comparing those to the benchmark values in the study from 2019. So our operative time, our length of stay, our CCI, clinically relevant post-op pancreatic fistulas, severe post-op bleeding, and in-hospital mortality were all within the benchmarks for both low-risk and high-risk patients. The high-risk group, in regards to blood transfusions, grade 3 complications, and readmissions, were slightly higher than the benchmarks. And then also, importantly, as far as oncologic outcomes go, our high-risk patients were within the benchmarks for open. The high-risk patients, the most common criteria was an ASA score greater than 3. And included in these patients, we did have those who had intraoperative findings of vascular involvement, and 5 of these were able to have a vascular reconstruction performed robotically. Any arterial involvement was a criteria for conversion for open. And this is a graph showing our institutional learning curve. And so over time, we did see a drop in conversion rates that was significant, and operative time as well. After between 40 and 100 cases, this was the most significant. Despite introducing a second surgeon into our learning curve and the robotic fellows as well, who also participate in performing these operations. As far as complications in our learning curve goes, after about 100 cases or so, we did see a decline in complications, and we labeled this as our maturation phase within the learning curve. So, in conclusion, robotic pancreaticoduodenectomy can be performed in high-risk patients at specialized centers. Outcomes can be similar to open in regards to the benchmarks that have been instituted after initial learning curve. For our institution, our proficiency phase was between 40 and 100 cases, and a maturation phase between 100 and 140 cases. Also, in regards to oncologic outcomes, robotic pancreaticoduodenectomy may show some improvements in regards to R1 resection rates, median lymph node yield, and 1-year disease-free survival, which were all improved over the benchmarks for open.